Here we are going to discuss the different joints and some of their diseases. So, first and foremost, we have to start off with arthritis. Here's the thing. There are a different 100 different types of conditions that are referred to as arthritis. Arthritis is simply a inflammatory or degenerative joint disease. One of the most common types of arthritis is going to be osteoarthritis. This is typically going to occur in we see it frequently in knees, we see it frequently in the cervical and lumbar spine, we see it in fingers, specifically the knuckles, but we also see it in the hips. That's some of the most common places. What ends up happening is osteoarthritis is also typically referred to as a normal wear and tear arthritis. Essentially, we have cartilage damaging enzymes that are released through normal wear and tear, and at some point they become excessive. In other words, we're destroying more cartilage than we're replacing. And when that happens, we get rough, cracked, eroded cartilages that then have abnormal effects on the joint. So this is the knee joint that's shown here, so we're going to talk about this based on the knee. So if that cartilage is rough and cracked and thin, it's not going to allow for smooth, easy gliding when we flex our knee. That's going to cause further damage to the bones that are and cartilage that are doing the gliding, and the body is going to try and minimize that damage or heal from that damage. And that to a cascade effect where we get bone spurs and we get rough bone ends. A whole bunch of different things can happen. We can get a narrowing of the joint space. We can get fusion of the bones together, so they're not really moving over each other at all. Of course, that's more end arthritis. Very early on arthritis, you're just going to get the rough cartilage. But towards the end, you can get decreased movement because of decreased joint space and the bone tissue itself thickening and forming bone spurs to bridge the gap to stabilize the joint because the cartilage isn't doing it anymore. Another type of arthritis is rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune inflammatory condition. It's typically marked by flare-ups. You'll go time frames or times where it's not really bothering you, and then all of a sudden will get really bad. Essentially what happens is the body creates antibodies to attack joint surfaces. Specifically, as far as we can tell, it seems to attack both the articular cartilage and the synovial membrane. So the synovial membrane is going to become inflamed and eventually thicken into a structure that is referred to as a pannus. This is an abnormal tissue that clings to the articular cartilage. This is going to erode the cartilage, form scar tissue, and eventually the two bone ends are going to connect together. They're going to fuse together. When it fuses together, it ossifies and fuses together, this is known as ankylosis. And this image right here is actually showing a classic, what we refer to as swan's neck deformity. All right, so this fusion of the bone is referred to as ankylosis. Yes, this might be redundant. I paused the audio real quick to answer a phone call. So I'm trying to regain my train of thought. Yes, that's what I was talking about. This picture is actually showing you a classic swan's neck deformity, as we refer to it as. The fingers are bending and curving towards the ulnar bone. It's known as a swan's neck deformity. Rheumatoid arthritis is typically seen in women, but men can get it as well. It does seem to have a genetic link, so if one person in your family has it, it is something to make sure your doctor knows so they can keep an eye on whether or not you might be forming it. It does typically present in the 30s, so early to mid 30s, 30 to 35. It's usually when people start noticing and presenting with symptoms of rheumatoid arthritis. But that does not mean it can't start earlier and it can't start later. Here's a comparison. This is a normal joint. That same joint in an osteoarthritic patient, the bones are rubbing against each other because the cartilage has completely disappeared. And here we have a rheumatoid joint. Swollen, inflamed, very thick joint appearance, but eventually these will also fuse together. Now, another type of arthritis is gout or gouty arthritis. So when we break down nucleic acids, DNA, RNA, we get as a byproduct uric acid. Normally, that uric acid is removed from our system via our kidneys through urine. Now, sometimes the kidneys just aren't able to do their job. They're not able to manage it. Either we have decreased excretion or we just have an overproduction and the kidneys can't help maintain that. Kidneys are damaged in some way. We have kidney disease. Something's going on. When that happens, that uric acid can build up in the blood, and when it does that, it can crystallize, forming needle-shaped crystals in the joint spaces. These needle-shaped crystals are going to cause an inflammatory response because they are going to start stabbing all of the soft tissues. When they start doing that, we get this inflammatory response, we get this healing response, and we get swollen joints. However, they are painful swollen joints. One of the classic places is actually not this toe. The classic toe or joint to get gout presentation in is actually the big toe. It's a very classic example. And strangely enough, from a homeopathic standpoint, tart cherry juice, unsweetened tart cherry juice, seems to do something to help dissolve these uric acid crystals. We don't know exactly what. We don't know what role it's playing. Last I heard, they were doing some research on it, and I haven't checked back in on it. So for all I know, there is research out there actually explaining this now. But it is something that you'll have even your primary care provider say, oh, drink some tart cherry juice. It will help with it. And it seems to in most people. But last I knew, we did not know why. Bursitis. What is bursitis? Bursitis is a swelling and inflammation of a bursa sac. This is usually due to overuse. You have done one particular activity too much, or you have done one activity too rapidly. What do I mean by that? You go from not lifting to lifting 25 pounds over and over and over again. You go from not running to all of a sudden running 10 miles a day. That's typical presentation for sudden changes in activity, but also if I just if I play tennis every single day for several hours a day, that would be an overuse injury. However, we do also notice bursitis in overweight individuals, and they tend to classify that more as an overuse. That being said, bursitis can also be a reactionary mechanism due to trauma, arthritis such as rheumatoid arthritis or gout, just general infection. Sometimes, though, we don't know what's causing it. You just have an inflamed, angry bursa sac. The most common areas to have bursitis are going to be your shoulder, your knee, your elbow, your hip, the joints that we tend to use a lot. We have seen the Achilles tendon in the foot, though, just not nearly as frequently. Can it happen in other bursa sacs and other places in the body? Yes, just not frequent. What's the treatment? Rest. Don't use that joint. Use it as little as possible. Yeah, I know. It's not great. Now, in extreme cases, we can do like anti-inflammatory injections and stuff like that, but they're not considered best practice in most instances because they have more side effects. So, a lot of times, the first thing they will try is rest. Tendinitis, exactly what it sounds like, inflammation of a tendon. This is going to typically be due to overuse or repetitive motions or a sudden use of it. What sudden use? To use that example of running, I go from running 0 miles a day to all of a sudden running 10 miles a day. That can have serious consequences for your tendon because they're not used to that sort of activity, and that can cause inflammation and irritation. Again, rest is usually the treatment for this. Disc herniations. So a disc herniation is when that inner jelly of a intervertebral disc has squeezed through the outer tough connection or covering and is now protruding into a space, bulging into a space where it's not supposed to be. Now, depending on how it protrudes, you may never notice it. There was actually one study done that they took MRIs of individuals because, first thing, disc herniations can only be diagnosed with MRIs or CTs. You cannot diagnose them with a X-ray. You can suspect, but you cannot diagnose based on an X-ray. You need soft tissue imaging. So they did MRI imaging, and they found that people who had no back pain, no nerve issues, no signs or symptoms of a disc herniation, many of them had disc herniations. They were just protruding in a manner that did not impact the spinal cord. And then they actually repeated that same individuals and they retook the images, I think it was like 6 months or a year later, and those individuals' disc herniations had disappeared. Why do I tell you this? The body is an amazing healing mechanism and will, when it is able to, heal itself. That being said, sometimes it can't. And sometimes it is too bad for it to. It will try and it will do a little bit, but it just can't do it. This is usually very common, the fact that it can't heal itself or it can only do a little bit, if there is trauma involved. So you had some sort of accident or you had a sudden heavy weight or pressure applied to the disc that caused a forceful bulge. You did heavy lifting. You did repetitive twisting towards one side, so that repetitive motion. That can cause a disc herniation that is unable to self-resolve. It's unable to fix itself. And that's usually when you end up with signs and symptoms, radiating nerve pain, that sort of thing, and you need to seek professional help. Now, what is a sprain and what is a strain? A sprain is going to be an injury to a ligament. So this can be a sudden overextension of the ligament, or it can be due to repetitive motion. But it is the ligament that has been injured. A strain is going to be, again, still due to a sudden overextension or repetitive motion, but a strain is going to be injury to a muscle or tendon. Can I have both a sprain and a strain? Absolutely. But there are tests to help differentiate if it's a sprain, a strain, or both. And lazy doctors will just say, oh, you have a sprain strain, and not do that differentiation. All right, there are some things that we're going to throw in here, because this is kind of a catch-all, that our nursing instructors think you should make sure you are really paying attention to. One of them being calcium is essential for keeping your muscles moving. In particular, your diaphragm. Diaphragm has to keep going every single minute. It does not get a single second off. So having enough calcium is really important. The other thing they want to make sure you are staying up on is the difference between osteoclasts and osteoblasts. Osteoclasts are going to break down your bones if they need to bring blood calcium up to where it needs to be. And this is going to involve vitamin D and parathyroid hormone release. Osteoblasts are going to involve calcium, estrogen, and testosterone, and take take calcium out of your blood and put it into your bones for later usage. Phosphate, stored in bones, tends to get regulated along with calcium. So we don't talk about it. It's just assumed that you know that it is going along with the calcium. So if calcium is leaving, so is phosphate. If calcium is being stored, so is phosphate. All right, back to our normal scheduled program. Bone fractures. Bone fractures have a variety of classifications, but general classifications are going to follow a couple of premises. 1. What position are the bone ends in after the fracture? How complete is the break? So is it all the way through or only partially through the bone? What orientation is the bone on the long axis? So has it twisted at all? And has the bone broken the skin? So if it is non-displaced, it means the bones have maintained their normal position. If it is, which is what this image is. If it's displaced, the bones are no longer in their normal position, such as this breakdown here. If it is a complete fracture, it has broken all the way through, such as here. If it is an incomplete, the bone has not completely broken all the way through, such as here. Stress fractures tend to be incomplete fractures. Also, annoyingly enough, stress fractures typically have to have ACT done to pick them up. They're not always viewable on an X-ray. A linear fracture is when the fracture is running parallel to the long axis of the bone, so it's running the length of the bone, such as this one right here. Transverse fractures are when they run perpendicular, so they cut through, such as this one right here. Simple or closed fractures are going to be used to describe when the bones do not break through the skin. However, compound or open fractures are going to be is the term used for when the bone breaks through the skin, such as this picture here. Comminuted fractures are when the bone has broken into 3 or more pieces. These are very common in the elderly. Why 3 or more? If you have a simple fracture, you are going to have 2 bone fragments because it's breaking through. You're going to have the top piece and the bottom piece. So if I have 3 or more, that means we have multiple fracture lines, such as in this image here. So this is the X-ray, and this is the artist rendering. We have a fracture running here, separating the top from the bottom, but we also have another fracture here, separating another piece from the top and bottom pieces. Spiral fractures are going to be a ragged break that kind of twists along. It's not parallel or perpendicular. These are typically due to excessive twisting. Very common in sports injuries, but also super common if somebody twists and forces your arm up behind your back. Compression fractures, typically seen in the vertebrae, but can happen in other porous bones. This is when the bone is crushed. It's not necessarily like broken in pieces, but it has been compacted. A depression fracture is when the broken bone portion is pressed inward. These are typically going to be seen with skull fractures. We can also have fractures at the epiphyseal growth plate, and these are actually divided into categories 1 through 4, depending upon how complete the fracture is along the growth plate and if it takes any additional bone with it. So if you go into orthopedics, you're going to end up seeing these and getting very comfortable with their classifications. But an epiphyseal fracture is when the growth plate or the epiphysis separates from the diaphysis along the plate. Typically, this occurs frequently during a growth spurt. Growth plate is fracture is going to increase calcification. Bone is it's going to stop growing. So this can cause a growth spurt to end early. Also typically due to sports injuries in growth spurts or during growth spurts. Green stick fractures. Green stick fractures are incomplete fractures where one side of the bone breaks and the other side bends. Typically seen in children because their bones are partially bone and partially cartilage. So this is easier to do. All right, so that's some fractures. Mind you, that is the tip of the iceberg when it comes to different types of fractures. There are so many more. But if I have a fracture, it needs to heal. So what's going to happen? When the fracture occurs, the first thing that's going to occur is extensive bleeding into the area. Over the course of several hours, we are going to form, a large blood clot, otherwise known as a fracture hematoma, in that area. It's going to kind of envelop and work to stabilize the fracture. Once that hematoma has formed, bone cells are going to become deprived of nutrients and die. We're going to get swelling, pain, and inflammation. This is going to trigger granulation tissue to form. So the hematoma is going to be infiltrated by capillaries, so blood vessels. We're going to get macrophages coming into the area. These macrophages are going to clean up debris. We're going to get some fibroblasts producing collagen fibers spanning the break, again helping to stabilize it. During this process, we're also going to get the formation of chondroblasts or cartilage cells. These are going to start to secrete the cartilage matrix. From there, we're going to have some of these chondroblasts form into osteoblasts. We're going to start to form a spongy bone. And at this point, this is known as a fibrocartilaginous callus, and it's going to splint and stabilize the broken bone. And it literally, if I were to take another x-ray at this point, it would look like a bump. So instead of a nice smooth bone traveling down it, it will have a massive bump in the middle. From there, we're going to get bone trabeculae or spurs that are going to increase in number and convert that callus into a bony callus made up of spongy bone. This takes about 6 to 8 weeks. From there, that spongy bone is going to be continuously remodeled. We're going to get cortical bone involved, and we're going to eventually reshape that callus into its normal structure, the way the bone is supposed to look and function. So I'll have a spongy bone, bone marrow, compact bone on the outside. It returns to its original shape and structure. But that takes several months. That is the end of bone diseases. That is also the end of Unit 5. See you again in Unit 6.